We're going to go ahead and get started with our panel this afternoon. I'm going to go ahead and introduce all three of our speakers. So first we have Dr. Mary Ellen Wewers, and she is a professor in the Division of Health Behavior and Health Promotion and Director of Faculty Development at The Ohio State University College of Public Health. She holds a doctorate in nursing from the University of Maryland and was trained as a nurse practitioner in primary care. She has a master's degree in public health from Harvard, and Dr. Wewers has been NIH funded to conduct tobacco-related research since 1988. And I also have Dr. Amy Ferketich. I knew I wasn't going to get that right, sorry. Ferketich, and she's an associate professor in the College of Public Health at The Ohio State University. She has a master's degree in applied statistics and a doctoral degree in public health with a specialization in epidemiology. Currently, her research focuses on tobacco control and applied survey methodology. In tobacco control, she's been involved with tobacco dependence treatment interventions, targeting underserved smokers, and evaluation of the smokeless tobacco marketing strategies in the Appalachian region of Ohio. And then finally, rounding out the panel is Dr. Jane Hamel-Lambert, who is my counterpart at the Appalachian Rural Health Institute at Ohio University. She's an associate professor of family medicine and the director of ARI at Ohio University. In 2008, she was named the first faculty fellow in Engaged Scholarship at OU, through which she led a faculty development initiative and community-based participatory research, which is actually how we met all those years ago, and her investment in community university partnerships has inspired the development of integrating professionals for Appalachian children, also known as IPAC, a rural health network to improve access and quality of health, mental health, and allied health services in southeastern Ohio. So please give me a round of applause and for all of our speakers this afternoon. I'm going to let them all talk for a few minutes here, and they have promised to keep it fairly short, and then we're really going to open this up to questions. So please think of questions so that I don't have to ask them all. Okay. All right.
There should be a handful of slides.
There we go. Oh, well, uh-oh. That's right, there should.
Down at the bottom.
Is this it? Is that it?
Thank you.
Oh, sorry that we didn't have that. There we go. Do one of you want the clicker?
So is this on? Is this turned on? Oh, good. Okay. Well, thank you, Tanya, and thank you, everyone, for coming. I know there's a great talk next door or somewhere, so we appreciate people coming in and their interest in this topic. And you've heard a lot today about community-based, engaged, involved, participatory, all the different labels that we attach to community work. So we promise to each just do one slide and a lesson we've learned in the work we've been doing for many years. So I will get us started, and in my one slide I'm supposed to mention the project that I'm currently involved in and want to just give you a little snapshot of what that is. And this is actually a group randomized trial where we're testing implementation of a model. And the model that we have constructed and designed and are testing partners a community county level health department with the Ohio State University Extension and a lay health advisor. So we are delivering the U.S. Preventive Health Service guideline, so an established protocol from the U.S. Public Health Service that describes, dictates, recommends what is scientifically valid treatment. So we are very much obliged to deliver in a community setting or a county setting an established recommendation for tobacco dependence treatment. So we are combining behavioral counseling with pharmacotherapy in the form of a nicotine patch, and we're testing the effectiveness of this model that includes a lay health advisor, a public health nurse, and Ohio State University Extension. We're testing that to look for effectiveness at 12 months after implementation of the protocol. So one of the lessons that I wanted to talk about is in community-engaged, community-based, community-involved research, where we definitely want to partner with different communities and be able to tailor and design care. How do you accomplish that when you're obliged to deliver an established protocol that's already been set by, in this case, the U.S. Public Health Service? And I should mention that we've been funded by the NCI to do this work. So we also need to be good stewards in terms of spending our government's money, our taxpayers' money, everyone in the room's money in terms of doing what we promised we would do, and being respectful of our community partners, but also making sure that we're doing the study again, following the guidelines. So one of the things that I decided I would talk about is how do you remain faithful to a research protocol or an intervention when we are in partnership with communities who may have different ideas, and knowing their community as well as the community residents do. How do we accomplish the aims of the study, the protocol, and the community's wishes? So one of the things we work very hard to accomplish this is with our training and very explicit hiring, letting people in the community who apply for our positions, because we only hire local staff. We don't bring people from here in Columbus out to our 12 counties. We work from within the county in terms of hiring people, hiring field staff, training field staff, working together. So one of the things I've learned in all the years is that the more guidance we can give with training, the more explicit we can be, the more research manuals, treatment manuals, explicit instructions to our staff. That goes a very long way when we work with community residents who perhaps feel that a different way to deliver treatment may be better served. So as we get going and talk about examples, I'll be happy to talk about some of the, again, stories from the field that I've dealt with in terms of working with community residents, working with healthcare providers, and working with the agencies themselves when there's been what I would call a tension between the different objectives that all of us are partnering together to achieve. But I hope that when all is said and done, that the fidelity to the protocol and to the guidelines and to the implementation of the study will result in valid research findings that can then be used by the community agencies themselves as we continue to go forward together in these types of partnerships.
Okay, all right. Okay, hello everyone. I'm going to talk today about some research that I have recently finished in the Appalachian region of our state. And this project involved conducting a smoking cessation, or really tobacco dependence treatment intervention through healthcare providers and healthcare clinics in Southeast Ohio. So for this project, we conducted a group randomized trial, and we were in 8 clinics in Southeast Ohio and in several counties. And 4 of the clinics were intervention clinics and 4 were control clinics. Now, the goal really in both groups was to deliver information to the clinicians about the 5 A's and the clinical practice guideline. But in the intervention clinics, we kind of pulled out all the stops, had lots of bells and whistles, very nice. There was a very nice educational session that was delivered by a physician who talked a lot about how to incorporate this information very easily into clinical practice. We also, in the intervention clinics, gave the physicians information that they could use when they were talking to patients. So we gave them binders for the exam rooms. We gave them posters with information about pharmacotherapy. We gave them information about what Medicaid covered in terms of pharmacotherapy and what the prescriptions cost for the patients. And then we also identified in each intervention clinic an office champion. So this would be somebody who's really excited about delivering smoking cessation intervention information to patients, and somebody who could really keep the intervention going after we left the clinic. So we were essentially taking all of the recommendations in the clinical practice guideline and delivering it in the intervention clinics. Now, in the control clinics, we also gave the physicians information about the 5As, but we just gave them the clinicians' version of the clinical practice guideline. It was a short, like 15-page PowerPoint presentation, and so I briefly went over the information with them. So they essentially got the same basic information about the 5As, about the pharmacotherapy options that Medicaid covered in Ohio, and then we also gave them information about the quit line, because the quit line's still providing counseling for Medicaid-enrolled smokers. And so from each clinic, we then wanted to enroll 30 smokers who were enrolled in the Medicaid program and were just coming in to see the physician for, whatever reason. It could have been a physical or some sort of health check, some scheduled appointment or screening. So they were just coming in for an appointment. They weren't necessarily interested in quitting. And so we recruited them. We just told them, that we're doing a smoking study. We wanted to ask them questions about smoking. And then we enrolled patients. And again, the goal was 30 from each clinic. And then we questioned them at 1 week to find out what their physician talked to them about. If the physician talked about quitting smoking, basically did the physician deliver the 5As. And then at 3 months, we also contacted them to find out if they were currently smoking. Then we asked them some questions about other questions related to smoking, and then about the intervention if they were in the intervention arm. And the smokers in the intervention clinic were also offered 12 weeks of free telephone counseling delivered by a tobacco treatment specialist. And so, what we found was that in the intervention clinics, over half of the participants enrolled in telephone counseling. And so, again, these were smokers on Medicaid who were not necessarily interested in quitting a week before. But, we were very encouraged by that result. We also found that a very high rate, 58% in the intervention and 64% in the control arms, had at least one quit attempt. Fairly high percentage, between a third and a half of patients got a prescription for pharmacotherapy. And then we also found, though, that the intervention arm was more cost-effective in terms of cost per confirmed quit than in the control arm. So we had, very good results, and so we're continuing research with Medicaid-enrolled smokers, and we, want to take this, make it into a much larger study. But what I wanted to talk to you about today was just some of the issues that we had working through healthcare providers and in healthcare clinics in this region. So there were some provider-related challenges. The first one was that recruitment was very slow initially. I contacted some individuals that I knew. I worked with 2 Medicaid managed care plans, and they suggested that some healthcare clinics in the region, and I reached out to them, but I was just having a really hard time finding any healthcare clinic that was interested in participating. So I found a local partner. I worked with one of my colleagues here on the stage with me, and then also with someone who's at the Holzer Medical System. He was the director of research at the time, and so I had 2 individuals who were we thought this project was extremely important, and then they did a lot of lobbying for me, and eventually I had enough clinics enrolled in the study, but it was challenging. It took several months to get that up to the 8 clinics that we needed for the study. And one provider initially agreed and then dropped out, so that was another challenge. It just turned out this person just really didn't have enough time to do the study, and so we just ended up recruiting one of his partners. So we, fortunately found a solution for that as well. And one provider switched his clinic from being just a regular primary care clinic at OU to being part of the community health center system, and so he, allowed us to move the study over into his new clinic. So that was good because we were about halfway through recruitment in that original clinic, so that would have affected our numbers. And then we also had quite a high turnover of the office champion, which we really didn't expect. In most of the clinics, we recruited a nurse who had been there for a while, but for some reason, in some of the clinics we had a turnover, so we just had to then go back to the clinics and find another person to replace the office champion. So those were some of the provider and clinic related challenges that we had, and then we had a lot of challenges related to this Medicaid patient population. First, one was that the no-show rate was rather high. We had heard that early on from office staff and physicians, but we certainly saw it when we were in the field. The interviewer would talk to the clinic. She would, perhaps she was told, okay, there were 3 patients on the schedule today, so then she would drive to the clinic, and then maybe one would show up if she was lucky. So that caused us to be in the field longer than we had anticipated. And then we also found that some participants were very difficult to reach at follow-up and then during the weekly telephone counseling calls because of their phone plans. So they ran out of minutes, or they didn't want to use their minutes for the study. So that was another challenge that we faced. And so fortunately, in all of our studies, we collect secondary contact information. So we utilize that information to get a hold of the participants. In the end, we had a fairly high participation rate in the 1-week calls and in the 3-month calls. And then finally, we had like one general Medicaid challenge, and that was one of the very large managed care plans was having some, I think, management problems, and so some of the offices stopped seeing patients who had this particular managed care Medicaid plan, and so that also cut down on the number of participants we were able to enroll. So the reward that I do want to focus on too, I talked to you about some of the challenges that we face, but the one I think going through healthcare clinics is a really good way to reach Medicaid enrolled patients, because we found in our analysis of the Ohio Family Health Survey data, and then this past year changed the name to the Ohio Medicaid Assessment Survey data, that over 90% of adult smokers who have Medicaid report having seen a healthcare provider in the past year. So a very high percentage of these individuals do go to see the healthcare provider. So it is a good way to reach this, otherwise difficult to reach population.
So good afternoon. It's getting late in the day and people are sunning down. You can feel it in the room. I think I imposed myself onto this panel under the heading of participatory methods, and because I'm getting fairly opinionated about how to pull that off well in communities. And it's funny, I forgot about that we had those early meetings about, this Amy woman called me from OSU, and somebody told you to call me, and how do we get you into the community so you could find places to collect data. So my story is very different. So I'm not an NIH-funded researcher. I don't do double-blind clinical trials. I have been in Southeast Ohio, in the Ohio University now for about 10 years. And for the better half of that, I've been involved with the development of what I call a university community partnership. And it's an incorporated 501c3 at this point. And its origins really were, I guess originally we were part of somebody's grant objective to convene a multidisciplinary table to accomplish everything for everybody at the table or something like that. And so the demand that we get together and figure out how to solve a problem was prompted by an external grant structure. But what happened over the next 3 years was I was involved with this group who really began to bring definition to how to do that. And so a table that in its earliest iterations were probably 85% plus academics who heard grant-connected research, who figured they had a place at the table, sort of gave way to a community structure. At this point, I'd say we're 85% community, 15% university, and a community who really began, arguably for one of the first times, to trust the university and to really believe that the university had at least the ability to leverage, if not just downright assets, that could be used well to benefit the needs of the broader region. So that table is the nonprofit Tanya referenced, IPAC, which is Integrating Professionals for Appalachian Children. And it set out to ensure healthy development for all the kids in the region. And to do so, not by getting bogged down. There were so many meetings when I first got to Southeast Ohio that the whole conversation was about what wasn't there, about the gaps in the delivery system and about the, I mean, we don't have a lot of things. We don't have a PEDS OT. We have a PEDS board-certified child psychiatrist if you enter this system first. And I mean, it's so resource thin that if your solutions come from filling in those gaps, you will be circulating in the same conversation for a decade. So we set a vision of ensuring healthy development for all kids, and then we set a mission to do it with what we had. And really what we had were a whole lot of people who you could get to come up with a decent understanding of the problem and a decent design of the solution. And 3 years later, and it really took 3 years. 3 years later of me coming to the table, dropping down grant opportunity after grant opportunity, and going, oh, no, we don't want to do that. We don't want to do that, because even when I tried to introduce Amy into the community, right, they're all going like, oh, no, those researchers, they don't really understand. Oh, they say it's not going to be any work. Remember this conversation? Yeah. Say it's not going to be any work. Oh, they're going to give me somebody in my office to register people, but, oh, then my people have to deal with you or somebody. I mean, and so they had this, I mean, they'd really been acculturated to just say no to anything that sounded like grants or research. And eventually, they said yes. And because we had been at the planning process as a collective body, and so this group was anybody who had something to do with influenced kids. So it was meds, it was nursing, it was schools, it was early childhood. It was a great group of people, and from the university side, it was health comm folks with the messaging strategies, and I was psych, and we had social work, and I mean, we just had a wonderful blend of voices whose brains all came to bear on a solution. And by the time we wrote that up, we were fundable. And then we wrote up the next idea, and it was fundable, and then we wrote up the next idea, and it was fundable, and then we wrote up the next idea. And we've lived in that space. And I wanted to share that story because early on, you know, I'd talk about the win-wins, you know, not entirely cliche, but in a recognition that to get two parties to stay in a project, both parties really had to get something out of it. But over the 10 years, there's too much endorsement to the idea of a shared vision. I don't recommend you don't have one. I think everybody needs a shared vision, but there's a lot of happiness in the shared vision, and there's a lot of belief in the outcome. It's coming up with the same outcome is not the challenge. People easily say, we want it to come out this way. It's the process of getting there. It's the process of hiccuping through the turned over staff and hiccuping over the site-specific. Honestly, we know how to do it better than your U.S. your U.S. guidelines, and we did so successfully because of the trust and transparency that came out of that multi-year conversation. And we have been very successful with that. And I think that's something people need to think about. If you're going to enter a community, to really see it as a long-term partnership, to see the potential in the long-term partnership, and to try to create a space. I mean, we did so very formally. We incorporated a body and really codified permission for people to come to the table and speak towards an agenda other than their siloed agency interests. It doesn't have to be that formal, but it was in creating that space. And this group, I mean, we're talking first Wednesday of the month for the past 10 years. This group has been meeting. And I'd say 70% of the people at the table are the same as there were at the beginning. And creating that space where people could come together to think out loud and plan together really worked well. You could argue it was a luxury of a lot of circumstances, and it was and continues to be a much greater challenge. I used to talk in this dartboard analogy that how do you get a community member to stay at a table? And I'd say, oh, for the community agency partner, it's the whole dartboard. Well, how do you get the academic to stay at the table? Well, academics will stay at your table conversation if you are the pinpoint of the dart. So you would have these agencies who, if it was good for kids, that was about all the pitch you needed. And then you'd have the academics who really came with a very valuable skill set, but the dartboard had to have space for their pin, and it got to be a very interesting dance between how to balance stakeholder interests and how to balance what people needed to stay at the table. And honestly, people will continue to participate, sort of the Commonwealth, echoing the Commonwealth theme. If there's value, I mean, if you're creating value, people will keep coming. And we haven't kept everybody at the table, and we haven't set out to do everything we wanted to do the way we intended to do it. But I just would like folks to think about how, when the project ends, how can you continue to be connected to the communities? Because I think there's a wealth of opportunity that yields from that, not the least of which is a bit of regional representation. So now if somebody wants to come to Southeast Ohio, it's not unusual if somebody says, well, go call Jane, and I'll try to network you into the right corner of the community. So, of course, we all turn over to read our slides. Yeah, I covered that. Yeah. So that's what my group's been about. You want to open it up for questions or discussion? End of the day, let's hear some energy from the room.
Okay, not everybody all at once. Questions, and please come to the mics because I know this is being recorded. Question for a particular individual or the panel as a whole? Oh, good. Thank you, Kathy.
I would like to know your thoughts. This might be more towards Dr. Wewers and Ferketich. Your thoughts on study participant incentive or reimbursement, money, or what they get for being in the study. What has your experience been, and what works, what's reasonable, and what the IRB is okay with, in terms of like not being coercive versus, what are your thoughts on that?
Thank you, Kathy. You're right. We have IRB challenges and issues, but we definitely want to reimburse all our participants for their time and effort and the value that they contribute to our research. We provide free drugs. We provide the free counseling, but specifically, we provide gift cards for every encounter, modest in many ways because of the IRB concerns about coercion, but we work with counties. Jane was talking about the regions. Every county and region, everybody's different. So we rely on our county partners to tell us what would be the incentives that would be best. We've actually gotten away from cash just because our university does not encourage cash so much anymore, and we're dealing primarily with gift cards. And what's interesting for us is because we do tobacco work, we were trying to find ways with the counties to avoid being able to purchase tobacco products. So that's we've had conversations about that, but mostly we've now, because of the economy and the gas prices, people have been telling us in most of the counties that gas cards are something that all county residents would like. We work with different vendors depending on the different counties, but generally we end up giving people in a year study about $120. I mean, no, I take that back. 25 at 3 months, 25 at 1 year, and 10 at 6. So $60 plus drugs and counseling.
And I just like to add, for Speedway gift cards, you can buy ones that you cannot purchase any tobacco or alcohol with.
Right.
So, yeah.
We prefer Speedway, but not all the counties have Speedway. So we use Marathon. We use we've used Kroger. Some counties want us to use their local gift cards to support, the shops that are in like Claremont County has a group that wants us to use local.
I still use cash for all the in-person visits when there's an interviewer there who can, hand the cash and then get a signed form from the participant. So I give about, I think $25 for the in-person interviews because they take longer. But then for phone interviews, I will just give usually a Walmart card. Like if it's just a short interview, maybe like a $10 card. For the physicians, however, I had to give them a lot of money to participate, and that's what I heard from my contact at Holzer. Like, they get a lot of money to do drug studies, and so I had to give them a lot of money to participate in my study. So yeah, they were a lot more expensive. But for focus groups, though, too, I think. I'm not sure about your experience, Marilyn, but I've been giving out more for focus groups lately because participants, have to drive to a location and then spend more time there. So for focus groups, it might be like, $30 or $40.
Amy and I do a study together on social networks. It's a different type of study, but we started out giving $25 for an hour in-home interview, and our participants said that really wasn't enough. So for that study, we had to go back to the IRB and up it to $50 for an in-home interview. Our IRB approved that, and the number of people interested in the study increased significantly. So for whatever reason, this 25, and I think maybe it's because it wasn't, most of our studies are treatments where we, give free medication and free counseling, and the participant sees it as a service. And something that, they're seeing direct benefit to them in assisting them to quit smoking. But for this other study, it was just an interview. So there wasn't the other additional benefit. So I think maybe that was partially responsible for why participants were more willing to engage when they saw the $50 reimbursement than the $25.
Anything else? Go ahead. Or you have something?
I want to make a comment about what you just said and then ask you another question about it. I'm almost finished with data collection on a study where I was doing interviews, and I had a $25, and it wasn't enough, and I upped it to $50. And I still had a hard time recruiting people, but I finally got the number, almost finished with it. And it was an interview study. It wasn't an intervention study. And people told me the same thing that you just said, that, you know, that they're not getting anything out of it except, you know, the cathartic experience of telling their story. But the other thing that people told me, because I probably only managed to recruit 25% of the people that I contacted, probably less than that. And I had graduate students contacting them too. People who lived in the environments that they were trying to recruit. And my graduate students said that, and they're all Appalachian people. My grad students are from there. And they said, you don't understand. We don't want people coming in here and telling and asking us our business. We don't want to tell you our secrets. That's really private to us. We feel like you're coming into our home and into our community and asking us questions that we're not so sure that we want to give you the answers to. It was a humbling experience for me, because as a nurse, I like to think that I ask very sensitive questions, and I had to realize that maybe no questions are sensitive enough for people to tell their private business to. Yeah. I mean, I'm wondering if you have had that same experience.
I was going to say, I think that's a really good point, especially about Appalachian culture. So have any of you encountered that in your studies, and how did you not adjust for that, or tailor, I should say, your intervention?
Well, we've both been on a study that's looked at reducing cervical cancer, and a lot of some of the work has been observational, where it's survey related. And actually, it's interesting you say that, Chris, because we've had just a very different reaction. But we didn't have graduate students collecting data. We had our county residing interviewers, and in fact, the most recent study finishes the hour-long interview with a module on intimate partner violence and childhood violence and different kinds of sexual violence, physical, sexual, verbal, many different forms of violence. And we have something now like over 200 women, and we end this with this module, and there's always opting out, and we've had, I would say, 90+% women who want to tell their stories. So I don't know, it's just anecdotal. I don't know if it's because we hire lay staff on our projects to conduct the interviews, and if it's because that people are more comfortable. I don't know, but that hasn't been our experience.
So how long would you have been working with that? Like, how long would you have been working with somebody who was then asked to enter into that conversation? I mean, is this at the end of multiple visits?
No. It's a one-time, 1-hour interview in the home or at a place where the participant feels comfortable. They decide where the interview takes place, and it's our first encounter. The interviewers have worked with us for over many years, but it's a one-time encounter.
It reminds me of our Family Navigator program, which is a community-based resource we've developed to help empower people to participate in their healthcare decisions and to recognize that they do have a voice when something isn't working right or the outcomes aren't as expected. Here's a doorway to enter, to talk out loud and share a story and figure out why that might be. And I think what that program would say is you asked. You asked respectfully, and I know in our conversations we have a lot of women say, nobody's ever asked, nobody's ever allowed me to tell my story. And similarly, probably not the first question in the hour, but after you get a sense of somebody's genuineness, you probably have very talented interviewers. Yeah.
Good questions, yes.
Yeah, so one of the problems with traditional research is that you get a recruitment bias. So oftentimes when you put out flyers and things, the people that contact you are the very most motivated patients, and they're not really representative of the general population of that group. So in coming up with a research advisory panel for a study, we want to get patients' input, but how do you find the individuals who are really part of the general community rather than just those few who are very motivated to do things like this? How do you reach kind of the average person within that group rather than the types that tend to seek out research?
Can you clarify? Do you mean for to participate in this study or to participate in an advisory capacity?
No, to participate in an advisory capacity.
Well, I work very closely with with a partner at Holzer Clinic, and then so when we were looking for a Medicaid patient to serve on the advisory board, somebody in the research department was able to, reach out to some Medicaid enrolled patients and invite them to participate. And so, but I don't know how representative this person is of, all of the Medicaid patients, but, that's my one example of how I've been involved with that.
I would also encourage you to think about if you build an advisory structure, don't create it as professionals operate. Recognize that people might be willing to come to 1 or 2 meetings, but they might not want to be able to serve on your advisory committee over the 24 months. That they have children who they have to pick up at school for 2 o'clock in the afternoon, so don't schedule your advisory board meetings at the pickup hours. Recognize that all of your professionals sitting at a daytime meeting are likely getting compensated for their time because it's part of their job, and try to figure out what the right level of valuing your consumer participation is in terms of how they would assign value to the process. I know we have had much more luck sort of convening groups to get opinions on topics than sustaining ongoing monthly structured meetings. And so I think in how the structure of the advisory, how you structure that function can affect people's willingness and interest really in participating. Other than that, I think it's really demonstrating back that the advice affects the project. And that you can show the iteration of, we talked about this and here's the decision we made. I think people disengage really rapidly when they're continuously asked to sit in an advisory capacity, but there's no evidence that any of their advice is ever taken. And to the extent that, we're guilty of this at IPAC, we have consumers on our board, but it's taken a long time for the consumer voice, who's 1 out of 15, to really feel they get equal mic time. And at one point, we even talked about having the reverse board, a consumer board with a single professional representative on it, to really try to elevate that consumer voice in our planning efforts. I think it's a challenge.
Good question. I just would also say that sometimes getting people who are interested, even if they're in that demographic of who your target audience is, that's not necessarily a bad thing, because there might be the people that actually then do come back and show up and are involved. So even some of the people that show interest, I wouldn't necessarily turn them away if they're in the target demographic. Yes. Yeah.
So much of the work that you've done has involved providing services or prescription drugs that people enduring health, underprivileged people have not been able to get. How do you see the Affordable Care Act and the increase in Medicaid and people's access to health insurance? How do you see that having an effect on your work, either in positive or negative ways, or both?
I think it'll be positive because certainly, for a number of years, Ohio's Medicaid program has offered all of the standard and recommended pharmacotherapy, and prescriptions have been either free or $2 if it's a brand name drug. So Ohio has really been great for a number of years. But now with the Affordable Care Act, there's a mandate to also provide counseling to pregnant smokers who have Medicaid. And so that's something new, and they can actually bill for it in Ohio. And I believe there's another requirement for like all of the exchanges that they can't refuse to cover pharmacotherapies for smoking cessation. So they have to be treated like all other medications. So I think it's a really good thing because more people now will have access to pharmacotherapy.
I think too, you talked about this morning, Bill, but having the cost effectiveness piece of that, and I think Amy's studies looked at that. We're looking at that too, so we'll be able to again provide exchanges, different groups, the information about the cost and the hopefully long-term outcome effectiveness.
I would also strongly endorse Medicaid expansion. I think for many people, they really believe that there's Medicaid if you're poor, for everybody. And when you work with this population, every day you hear stories of people who can't get health care needs addressed because of a barrier called insurance. And it's that simple, and it's any expansion to the eligibility that comes into play will expand the number of people who are eligible. What the provider population is going to do to meet the expanded ranks and the importance of really looking at scope of work and where licenses allow people to perform and to really sort of stretch our understanding of where skills lie in a healthcare delivery system to meet that expansion, I think is work to be done in our state and probably many others.
Do you think then that also will influence your relationships with introducing your projects into clinics, or perhaps the honoraria you'll have to pay to research participants because they wouldn't be getting, they would need to be getting the nicotine patch from you for free because they'd be getting it from their clinic. I'm trying to think about the whole gamut of all great repercussions, but I think that there are all sorts of I guess I'm asking you to brainstorm.
I guess an unknown still is what the copays will be, right, for all of these medications. So they still could be fairly high. So that might influence how we, do our research when we're, do we reimburse, or do we give them money for the copay, or do we just give them the prescription? What if they can't get the amount, say we, want to give them 21 milligram patches, but say they can only have a prescription for 14 milligram, then, how do we deal with that? Do we just give them the 21 milligram patches? Or so I think there are a lot of unknowns until we actually see what the exchanges look like, but that's really a good thing to think about.
Yeah, I think it just becomes a matter of understanding what becomes of value. So whereas today research subjects might enroll because they can get pills they couldn't get at otherwise, if tomorrow they get pills through Medicaid expansion, there's still something you can give that creates value in exchange for participating.
And Bill, our approach has been not to use the clinic. So we're trying to test the model that it's a community-based model, and given concerns about number of providers that will be available, who knows who to believe, what the projections are for will there be adequate numbers of providers. Our model is trying to be more of a consumer-friendly model that doesn't necessarily go through a clinic to provide treatment. So, you know, we may be, who knows, we may be more, yeah, it'd be interesting to look at the different approaches comparatively.
Any other questions? I know it's getting late on a Monday afternoon. Anybody have anything they'd like to ask? I have one question I'd like to ask. So, in doing your work, how do you position it with your community partners, or if you're going to engage a new community partner, how do you set it up so that it's of benefit to them, or what do you say to them to try to get them to be excited and want to be involved? Because I think we get it from the academic side, what we get out of it, but I'm not sure the agencies always necessarily see what they're going to get out of it. So how do you address that and overcome that in your research?
So what we do, first of all, our focus groups to find out what people want, what kind of services people want in their different counties and communities. And always tobacco comes up. Tobacco is always an issue, and access to care and treatment, and the high numbers of people who would like to quit smoking, so that is one way then we are able to say, here's a community base. You don't necessarily need a healthcare provider. I mean, we don't discourage people from seeing healthcare providers, but our approach or the model seems to be something that the community is looking for, services for people who don't necessarily have access to a health clinic or a provider, and that always has sold our project.
Okay. Anyone else? No? Any other questions? Okay. Any final thoughts from our panelists on community-based or community-engaged research?
They were superb.
Okay, let's give them a round of applause then.